increase in the number of publications in peer-reviewed journals, which is an indication of the importance of the data that we're generating. And then other people are reading what we're doing and citing it in their own work, and what you can see is that our work now is being cited about 250 times a year in other articles that people are publishing. And what are they saying about us? Well, this is in the New England Journal of Medicine in 2013. The novel approach of AREST CF has led to a paradigm shift in our current understanding of urban lung disease. The AREST CF data challenged the clinician to a more proactive approach in which we identify disease, treat earlier, potentially change the disease trajectory. And that's what we're after. We're after changing things early on to promote healthier lives and better quality of lives for children and their families. And then just at the end of last year, in an article that Graham Hall will talk about in a minute, the AREST CF group has made tremendous progress in moving the field forward, for which the CF community is very grateful. Very different story to the one 10 years ago, when we couldn't get people to listen to us. So, with that in mind, I'll hand over to the researchers, and first I'll introduce Luke Garrett to present the data that Peter Sly was the first author for in the New England Journal of Medicine. This is the leading medical journal for clinical medicine. And I think, Luke, although I can't recall when I looked at his slides last night whether he's going to tie it into his own work at the moment, but I think he will be. So, Luke, would you like to come and present this data?
Thank you, Steve. You saved me the hassle of introducing this talk. So my name is Luke. You probably won't know me because I'm in the laboratory with the rest of the airway sampling group, and we process all the samples that are collected at the annual visits. So because we're hidden away, this is why we wear bright red polo shirts in order to be seen. This paper was important, as Steve iterated, and it's called Risk Factors for Bronchiectasis in Children with Cystic Fibrosis. So bronchiectasis is where regions of your airways that conduct air in and out of the lung have become damaged and weakened, enlarged, and so they're less efficient at moving air in and out of the lungs. So identifying it early and preventing bronchiectasis has dramatic outcomes in maintaining proper lung function for longer in life. So this study was really only possible with the way the AREST CF program is set up, and it was aimed to identify risk factors as early as possible for the development of bronchiectasis. And what we did is, at that time, we had 127 children under AREST CF program who'd been visiting from 3 months to 3 years of age, and they had annual visits. And from these visits, of course, we get the lavage or the lung wash, where we're able to see if there are any bacteria or bugs that might be causing infection in the airway. But just as importantly, we can also see what the immune system is doing, how active it is, whether it's too active. And at the same time, we also take images of the lung with the CT scan, which Tim will go into more detail later. And this allows us to look for the very mild changes that begin early in life, and we can return this remodelling, and part of this remodelling is bronchiectasis. So with this capability, the goal was to determine which risk factors we could identify in the lung wash for the changes that we see on the lung imaging with increasing age. And what we found is that at 3 months of age, children who had an infection in their lung wash were twice as likely as their other children with CF to have bronchiectasis at 3 years of age. There was a similar risk if there was trapped air in their lungs, and also if there was any respiratory symptoms that was noted by the clinician, as well as some other clinical conditions that presented birth. But what was particularly interesting was having the presence of an enzyme called neutrophil elastase. So this is actually an enzyme your immune system uses to kill bacteria once it's ingested the bacteria. But we know from adult lung diseases that if you have too much neutrophil elastase, it's associated with damage to the lung tissue. But what wasn't identified before was that even the very mild levels that we detect early in life, our techniques are sensitive enough to demonstrate that this is still important for lung damage and significantly associated with bronchiectasis later on. So what it means is that we were able to identify that the key cause of lung damage is from neutrophil elastase, and that this occurs very early in life. So as Steve mentioned before, a lot of focus hasn't been in children under 5 years of age. But it's also positive because it now offers up new avenues for therapy. So we've seen that in CF we've adapted antibiotics to treat infections earlier. We've used physio and medicine to help clean mucus. But this also opens up the potential to boost the anti-elastase levels that are in your body that protect tissues, so we can limit the prevention of bronchiectasis with time. And so this is where my work's come involved. So I'm currently to the end of my PhD, and my project was looking at taking epithelial cells from the airways of children with CF and exposing them to levels of this enzyme that we measure in the lungs. And what I found is that when neutrophil elastase is present, lung cells can't proliferate, they can't maintain attachment and form a barrier, and they're unable to repair adequately after injury. So this is what's demonstrated here. We can see that I grow these cells and then I wound them with a scratch, and then normally cells will proliferate and heal the wound like all tissue does. And if we plot the repair on the vertical axis over time, we can see that under controlled conditions, these epithelial cells will rapidly close the wound. But when the enzyme is present, they're unable to proliferate and close the wound. But the other part of my project has been trying to model how we could treat the presence of this enzyme and try and restore conditions back to normal. So this is early work, but I've shown that by adding a drug which boosts anti-elastase levels and prevents the enzyme from functioning, these cells will quite happily return to their normal state and begin to close the repair. So moving forward, we have quite a lot of work to do to bring this to the clinic, but we hope to embrace our collaborators and our clinical trial experience that we're developing with Combat CF to bring this forward. I'm happy to answer any questions, but if you'd like any more details about this work, I've actually got 2 posters on the board just over the list, and I'm happy to run through them after.
Thank you very much for that, Luke. I was actually going to say that after each presentation there will be an opportunity to ask questions. So I would encourage you not to be shy, because if you're thinking of a question, the chances are someone else is thinking of exactly the same question, so get in quick. Luke and the other researchers will be available after the formal presentations, where we've got some drinks and nibbles, but they're likely to be in high demand. So does anybody have a question about Luke's research that they'd like to ask now? Yeah.
I was just wondering if there was any correlation between genotype and the damage to the lungs at all. Was that looked at?
The majority of mutations are classified under the severe genotype, so it's very hard to correlate genotypes to the amount of lung damage, but Tim will be able to answer that much more better than I am. He specialises in
it. Lauren Mott's here. She's a recipient of a CFWA top-up scholarship. She's published on this. So do you want to tell us what happens with genotypes and lung damage?
So the easiest way, because there's so many mutations, we're talking over 1,500 mutations that have been identified with cystic fibrosis. So to be able to say with certainty what any one mutation is doing is very difficult. We don't have the numbers to do that. But what we do is divide them into mutations that we classify as severe and those that are more mild mutations. And the way we do that is by looking at whether or not a mutation has absolutely none of the functioning protein, or whether there is some residual functioning protein. And if there is some residual functioning protein, we talk about that being a milder mutation. So I have presented a little bit of work on that at the North American Cystic Fibrosis meeting a few years ago. And what we found, we rather small numbers at that stage. So we have a better capability of doing that research again now with the increased numbers to get a better answer. But even at that stage, we could see that those children who had the more mild mutations, so the ones where there was some residual function of that protein, that they were less likely to have the neutrophil elastase in their lavage fluid in their lung that Luke was talking about. They were less likely to have infection, especially with important bacteria like Pseudomonas, and they were less likely to have respiratory symptoms, so either a cough or maybe some crackles or something like that when the doctor listened to their chest, and they were less likely to have lung damage on their chest CT scan, so that bronchiectasis, which we'll hear a bit more about from Tim, but also the air trapping, which is a bit of an earlier count. So we did already see that those children with those mild mutations with some residual function maybe have less disease in the early stages. I caution you that we don't know what that means at this stage. Does that mean that they will go on to continue to have less disease? Can we be a bit more relaxed about these children? We don't know that yet. So we can't make those sort of judgment calls yet, but that's sort of the early signs that we're getting so far. Does that answer your question?
That was a wonderful answer.
What I didn't say was that Lauren did publish some data on progression of lung disease related to genotype, and that was one of UWA's most cited journal articles last year.
Are there any other questions for Luke? I think we probably I'll go first and then Jonathan.
So I just didn't quite understand. So are these three lines? Is this healthy cell line or is this a CF cell line?
No, these are CF epithelial cells.
Okay,
Yep.
as a drug.
From patients.
Yeah, from
From
patients here.
Just ask, was it one particular drug that was used, or was it a variety?
So this is just boost. There's a molecule called alpha-1 antitrypsin, and its job is to prevent elastase from digesting tissue. So what happens in cystic fibrosis, you have infection and lots of inflammation. It's just too much for that molecule to inhibit. So this is looking at just restoring, if we could supplement that molecule in the airway and remove any elastase activity. And so that's what this is modelling. So it's sort of a natural way of preventing elastase from moving.
Well, Luke, thank you very, very much for your presentation. Ladies and gentlemen, Luke is also the winner of the Thoracic Society of Australia and New Zealand National Young Investigator of the Year 2014, and I think that we can feel very, very proud of him. He is about to submit his thesis and is the recipient of the CFWA McCusker Family Trust PhD Top-Up Scholarship, and I think that it's money well invested. Please thank you. Our next speaker is Professor Graham Hall. Professor Hall heads up the lung function team at the Telethon Kids Institute and is a senior researcher at AREST CF team. Graham will be presenting some work on the impact of respiratory infections in infancy and the impact on lung function in the early school years. Please welcome Professor Hall.
Thanks very much, Nigel, and it's a pleasure to see so many familiar faces. You may not have realised that I'm not in the lab doing lung function testing anymore. I hang out over here on the other side of the road, but still heavily involved. And I would echo what Jonathan said. One of the fantastic things about Telethon Kids and its research direction at the moment is that research around patients, around patient groups, and around how we can translate what we find into, in this case, clinical practice is a big part of what we do. And certainly for AREST CF is what really drives us. So the work I'm going to talk to you about tonight was done as part of our team here, but also in Melbourne. I guess that's something that Steve didn't touch on really, that Melbourne joined us in sort of 03, 04 and now basically copy everything that we do, which still bugs them. And so one of the key successes of AREST CF has been to involve other clinics in Australia, because as you know, cystic fibrosis is a fairly rare disease, and so it's only when you get more than one centre together that you start getting the numbers that you need to really find important differences. And so that's what we've been able to do here. So what we did in this work was look at what are the things that happen in the first 2 years of life when if you have children with cystic fibrosis who are coming into those large programs, and also you might remember the infant lung function tests where we wrapped the jacket around your baby's chest and we blew them up a little bit and we squashed them out a little bit and it looked pretty horrible. And then we tracked that through to what their spirometry and lung function was like when they were at school age. So this work was done by Catherine Ramsey. Some of you may remember her from the clinic. So she's not here tonight. She's at the Perth International Festival and is just about to head off to North Carolina as one of our collaborators to spend the next 2 years working in probably one of the world's premier CF research laboratories. And then we'll bring whatever she learned there back here to Perth as another example about how we